Welcome to another lecture by MedicoMedics. Herpes Simplex virus, a complete lecture. Now we will begin the lecture with a general introduction of herpes simplex virus. We will discuss pathophysiology, compare normal versus pathological. We'll talk about symptoms and syndromes, present a case example, discuss diagnoses, differential diagnoses, treatment, and end with a summary. And for our medical students, we recommend stopping and looking at our high-yield review. Now, herpes is a common viral infection caused by the herpes simplex virus, or HSV, which comes in two main types. So we have HSV-1 and HSV-2. Both can be sexually transmitted and are considered sexually transmitted infections, or STIs. Now, HSV-1 is typically considered oral herpes. Most often it causes cold sores or fever blisters around the mouth, but can also infect the genital area through oral genital contact. HSV-2, often referred to as genital herpes, primarily causes genital sores and is more frequently associated with recurrent genital herpes outbreaks. Now, HSV spreads through direct contact, mainly skin to skin, with herpes sores, or with saliva or genital secretions, and this occurs often during sexual intercourse, either oral, genital, or anal sex. Now, HSV can be transmitted even when no symptoms are present, through the process of viral shedding from the skin. So the virus can still spread from skin cells even if there are no visible sores, making it kind of hard to tell when someone is contagious. So symptoms typically in the initial infection is characterized by these painful blisters or sores in the infected area. You will also see flu-like symptoms and swollen lymph nodes. Recurrent outbreaks can occur after the initial infection when HSV reactivates, causing recurrent sores in the same area. Now, under normal conditions, the skin acts as a robust barrier, and the immune system efficiently targets viral invaders through coordinated innate and T-cell mediated responses. However, when these defenses are compromised or dysregulated, as in certain viral infections, pathological changes in the skin and immune function begin to emerge. So now let's turn our attention to the pathophysiology of herpes. So it all begins with entry and initial infection. So the virus, HSV, enters the body through mucous membranes or small breaks in the skin, often during close contact. We will then have replication and spread. So after entering, HSV virus replicates in the epithelial cells, meaning the cells on the surface of skin or in mucous membranes. Now this causes cell damage and leads to inflammation, which then leads to these sores. Now, after the initial infection, the virus travels along nerve pathways to nerve ganglia, so clusters of nerve cells, where it becomes dormant, hiding from the immune system. And many are found in the trigeminal and sacral ganglia, and they remain there for life. And then, under certain conditions, for example, from stress or other illnesses, the HSV virus can reactivate, traveling back along the nerve to the skin, causing new sores in the same area. So here we have an illustration you can look at. So HSV establishes primary infection within the host. Then it enters sensory nerve terminals at peripheral sites, seen here. It continues by entering trigeminal nerve ganglions, seen here. At the same time, it also establishes latency. Then we have the reoccurrence of infection in response to triggering factors. This will then reach the epidermis, and we then see the symptoms or the sores return to the same area. Now, herpes simplex viruses are neurotropic viruses, and they cause a range of mucocutaneous and systemic diseases depending on the viral type and the site of infection. Now, we have a diagram here that summarizes the most common clinical manifestations of both HSV-1 and HSV-2. So let's take a look now at how HSV-1 and 2 manifest differently in the human body. So let's start with HSV-1. Now, it primarily affects the upper body. So you'll see classic encephalitis, especially involving the temporal lobe. And this is a medical emergency. It can also cause keratoconjunctivitis, which is potentially vision threatening. Now, moving down, HSV-1 can cause oral and oropharyngeal diseases like gingivostomatitis in children, for example, or it can cause tonsillitis. Furthermore, for example, in immunocompromised patients, it could also affect the esophagus. In athletes, HSV-1 can cause something called herpes gladiatorum, which is a skin infection seen in contact sports. Now, while HSV-1 is mostly oral, it can still cause genital herpes through oral genital contact, as well as something called herpetic whitlow, which is an infection of the fingers, illustrated right here. Now, moving to HSV-2 then. On the right side here, HSV-2 classically affects the lower body. Now, it's the most common cause of genital and perianal herpes, and can also cause, of course, herpetic whitlow, seen here. Now, I would like to point out an important clinical consideration here. So, HSV-2 can lead to aseptic meningitis or even encephalitis, particularly during primary infection. Now, note that both viruses can cause oral or genital herpes, as seen here on HSV-1 and illustrated here on HSV-2. Furthermore, genital herpes is also pointed out here. But it will depend on the route of transmission. Now, the key distinction is that HSV-1 prefers the oral region and HSV-2 prefers the genital region, but they are not exclusive. Now, turning our attention a little bit to the right here, we see an illustration of the virus itself. So herpes simplex virus is an enveloped double-stranded DNA virus, and it has a icosahedral capsid. It's also surrounded by a lipid bilayer containing glycoproteins essential for host cell entry and for immune evasion. Now, seen here, we have 3 illustrations of the blisters typically associated with herpes, right? So the blisters associated with either oral or genital herpes, both caused by the herpes simplex virus, whether it's HSV-1 or 2, they typically begin as a small grouped grouped vesicles on a erythematous base or red base. Now, these vesicles are fluid-filled. So we can see it sort of illustrated here. You have this erythematous red base, and the vesicles are fluid-filled, and often we describe them as dewdrops on a rose petal. And it's due to their clear centers and the red surrounding skin. Now, they can appear in clusters and vary in number depending on the severity of the outbreak. So in oral herpes, for example, as illustrated here, they will commonly form on the lips, around the mouth, or inside the oral mucosa. While in genital herpes, illustrated here and here, they could appear on or around the external genitalia, anus, buttocks, or inner thighs. Now, these blisters are usually painful, burning, or itchy, and within a few days they will rupture, forming shallow, painful ulcers that eventually crust over and heal. And they heal without scarring, especially in immunocompetent individuals. Now, new vesicles may continue to form over several days, and during this time, the lesions are highly contagious. So then, briefly to summarize again, let's look at normal versus pathological findings. If we're talking about a healthy person, the healthy skin should be intact, smooth, no latent infection in nerves, and no signs of reactivation. However, if we're talking about a herpes-infected skin, we will be presented with painful blisters or sores. The virus will remain dormant in nerve cells, and we could see periodic reactivation causing recurrent sores. So then let's briefly take a look at a case example. We have a 32-year-old female. She complains of painful sores on the genitals. She presents with mild fever and swollen lymph nodes. These are all common signs of a herpes outbreak. We consider her recent history, specifically sexual history, and she tells us that recently she began a new relationship and had unprotected sex. In our physical exam, we see visible clusters of small, painful blisters and swelling, all consistent with genital herpes. Now then, how do we go diagnosing it? So we look first at the presentation. If we are presented with painful blisters or ulcerative lesions in the oral or genital region, especially when accompanied by a compatible patient history, this strongly suggests herpes simplex virus infection. We then turn to laboratory testing, so we can do a viral culture where we do a swab from an active sore, and this can be cultured to confirm HSV infection. We also have polymerase chain reaction, or PCR, helps us detect HSV DNA in samples from sores or blood, and this is a highly accurate test. We can, of course, do serology, so blood test. By doing that, we can detect antibodies against HSV. This would indicate past exposure, but it may not specify whether the infection right now is actually active. And seen here, for those who are curious, we have an illustration for the HSV PCR technique, including the oropharyngeal swab, where we do a cotton swab inserted into the mouth to absorb secretions, followed by the collected specimen, doing the DNA extraction, adding the purified DNA into our machine, and then looking at the test results. So if HSV DNA is present, it's now in high enough quantity to be detected, and this then confirms the infection. Now, when evaluating a patient with vesicular or ulcerative lesions, especially in the genital or oral region, it is crucial to differentiate herpes from other conditions that may look similar but have distinct features. So here you can see a list of different differential diagnoses of HSV, but right now we'll just take a look at two different examples. So let's take syphilis. Let's start with primary syphilis. Now, unlike herpes, syphilis typically presents with a single, painless ulcer, also called a chancre, that has indurated raised edges. And there's usually no vesicle stage. And the diagnosis of primary syphilis is confirmed with a positive RPR and treponemal test. So it's rather distinct from herpes. What about hand-foot-mouth disease? Well, hand-foot-mouth disease is caused by Coxsackie virus. Now, it can include vesicular lesions, but the distribution here is key. So you'll see vesicles on the hands, feet, and inside the mouth. So it's not limited to genital or perioral areas. And it is most common in children, and it's also not sexually transmitted. So if you know it, you can quite clearly differentiate it from herpes. Another one, which may seem a bit more difficult, is the varicella-zoster virus. And varicella-zoster virus, also known as shingles, may look similar to HSV because of the painful grouped vesicles, right? However, varicella-zoster virus lesions, they follow a dermatomal pattern. So they're usually unilateral and they don't cross the midline. And this helps distinguish them from herpes simplex. And as a final example, what about bacterial infections? Well, a bacterial infection like, for example, cellulitis or abscesses or infected ulcers, they can sometimes be confused with herpes simplex virus. But these lesions tend to lack vesicles, and instead they show purulent discharge or erythema and signs of common bacterial inflammations, right? So in summary, while HSV is characterized by painful grouped vesicles that may progress to shallow ulcers, it is the pattern, the associated symptoms, and systemic context that helps us rule out these important differentials. Now, before we dive into specific treatment for herpes simplex virus, it is important to understand how antiviral drugs work at the cellular level. So the illustration here shows a rather simplified overview of how a virus like HSV sort of hijacks the host cell machinery to replicate. So after entering the cell, the virus uses the host's ribosomes to translate its own messenger RNA into viral proteins. And this is a process that's essential for producing new viral particles. And antiviral drugs like acyclovir, for example, target this process by interfering with viral DNA synthesis, essentially blocking the virus from replicating its genetic material and forming functional proteins. So as you can see here, the drug binds to key viral enzymes or intermediates in the replication pathway, halting downstream actions and thus stopping the production of new virions. Now, these drugs don't eliminate the virus from the body, but they are highly effective at reducing symptom severity, shortening the outbreaks, and suppressing reoccurrence. So then let's turn to the medications. So we have antiviral medications. For primary episodes, typically it's acyclovir 400 milligrams orally 3 times daily for 7 to 10 days. Or valacyclovir 1 gram orally twice daily for 7 to 10 days. In recurrent episodes, again, acyclovir 400 milligrams 3 times daily for 5 days, or valacyclovir 500 milligrams twice daily for 3 days. We also use suppressive therapy. So for frequent recurrences, valacyclovir 500 milligrams up to 1 gram orally daily. Now, these antivirals reduce the severity and duration of outbreaks, and they also lower the risk of transmission. What about other symptom management? Well, for pain relief, so over-the-counter pain relievers, warm baths can relieve the pain of sores. The use of topical creams, so certain creams can soothe these sores, and although they do not sort of replace antiviral treatments, so what's important is this first one up here. Now, in summary then, herpes simplex virus is a common infection that causes recurrent sores, primarily around the mouth, HSV-1, or genitals, HSV-2. Now, HSV infects and damages skin cells, then hides in nerve cells, causing recurrent outbreaks when reactivated. Diagnoses: it's confirmed through clinical signs, PCR testing, viral culture, or blood tests. We treat it with antiviral medications to help control outbreaks, reduce severity, and lower transmission risk. And for you future clinicians out there, I would recommend taking a look at these extra tips here to not miss. So the ones mentioned here are herpes keratitis, neonatal herpes risk, CNS spread, and psychological assessment. So herpes keratitis is spread to eyes, which is an infection of the cornea. And if untreated, it can lead to scarring of the cornea, impaired vision, or even blindness if it's severe enough. Another important thing is CNS spread. So it can lead to meningitis or encephalitis. This is, however, rare. Another important thing to consider is the neonatal herpes risk. So untreated genital HSV poses a risk of transmission during childbirth. So keep that in mind. And finally, there is a quite strong correlation to a negative psychological state due to stigmas associated with visible sores, for example. So I would recommend a psychological assessment to avoid missing anxiety or depression or isolation, etc. And of course, other important things to prevent is safe sexual practice, avoid contact during outbreaks, partner notification and testing, etc. And here we have arrived at our high-yield review of herpes simplex virus. For you med students out there, we recommend stopping here and taking a look. And that's the end of the lecture. Thank you for listening. Please share, like, and subscribe for more weekly videos.